So hi everyone, I'm Dr. Mark Seveny. We're diving into something that affects millions of people, and children for that matter, their vision. I'm joined by two of the top experts in the United States, pediatric optometrist Dr. Timmerman and Dr. Robin Russell. If you could, just give us a quick introduction as to your background and what you enjoy.
Absolutely. So I'm a graduate from the Illinois College of Optometry, and then I also pursued a pediatric residency at Cincinnati Children's Hospital. From there, I worked in pediatric ophthalmology at Washington University at St. Louis Children's Hospital in St. Louis, Missouri. And then most recently, before starting with Cooper Vision full-time, I was at Nova Southeastern University, where I was in the pediatric department and also the director of myopia management. As of now, I'm at Cooper Vision full-time, where I help support with the professional and academic affairs for myopia management.
Wow, that's impressive.
Very good.
So we got our very own famous Dr. Russell, legendary here in Highlands County.
So I'm Dr. Russell. I graduated from Nova Southeastern, did my residency in pediatrics and vision therapy at SEO in Memphis, Tennessee. And then after I graduated, I came to good old Highlands County, and I've been here for, 17 years.
One thing, she has two beautiful children that keeps her super busy. So she, just left the doctor and with them.
Yes, yeah.
So she is very much super busy. So what are some of the earliest signs that moms need to look out for, especially in kids that aren't able to speak? What are some of the warning signs that you would encourage parents to look out for?
Yeah, absolutely. So in those children that aren't able to communicate verbally or maybe pre-verbal, we really have to look at their developmental milestones. So I like to ask about crawling and walking, and are they meeting those in a timely manner? Also asking about grasping, because that tells us a lot about their binocularity if they're using both eyes together. So really just seeing how that child interacts in their everyday. And of course we can also look for various signs, such as is that child squinting, closing an eye, or even if we see that those eyes aren't interacting together, if one seems to be turning inward or outward, which could be signs of strabismus.
I've also seen where kids will start all of a sudden doing this weird head turn, and the parents don't know that they're doing that, or they're closing their eye, or their eyes are blinking excessively, or they're bringing things super close to their face. Those are a lot of things that parents don't necessarily know that is normal or don't realize that they are doing it. So those are all signs that their system is trying to accommodate what they're doing too.
Yeah,
so
sure. So when should they first get an eye exam? So I have a baby that's fresh, newborn. When should I schedule their first eye exam?
I prefer to see their first exam between 6 months and a year, just to kind of get the baseline, rule out any major eye problems, myopia, strabismus, tumors, that kind of thing. And then I say around 3 or 4 when they start going into preschool, so they know that they're seeing correctly, learning their letters correctly. And a lot of times they don't know that they can't see, and we'll catch that.
Absolutely. It's so critical during those first few years of life to really be able to catch any problems, as mentioned here, that really could disrupt visual development and their potential, and really that short window of time to maximize that treatment. So
Yeah, I think the important thing to remember is the eyes develop outside of the womb. So as the vision is being developed, if we miss anything, that can last the rest of their life. So the sooner we can correct that problem, the better. So 6 months to a year, then possibly 3 years would be a good staple to follow. So as they enter into school, what are some of the common vision problems that we see with our school-age kids?
yeah, well, we know that myopia is actually the most common visual disorder for children 5 years old and older. So that, of course, is going to be the biggest one. And we see any type of uncorrected refractive error, whether it's hyperopia or myopia, astigmatism. But then there can be other visual potential disorders such as amblyopia or strabismus that are also quite common during that first decade of life.
And a lot of times if they do truly need glasses, when they read, they're not grasping what they're truly reading. They're struggling to comprehend. Even their eye teaming, things blur, things double up on them, and they just assume that it's normal. So us doing a thorough evaluation will help catch that. to make it easier for them to do in school.
Yeah, so a lot of the vision problems impact their reading, their learning ability. So any type of visual disruption really impacts their self-confidence, even if they're struggling to read, for that matter. So screens, we got a big deal with screens. So how are screens impacting our kids? We hear and we see a lot about kids with these screens. So give me your input on that, your thoughts on that.
I feel like the excessive screen time, we are seeing an increase in myopia. Even like the younger they start, even astigmatism is starting to change from where it had been as well too. They're not getting outside and playing like they used to. And I remember when I was a kid, I never did anything with the screen. I was outside running around the town, you know. But
Yes.
the kids just don't do that like they used to. So I think trying to limit that and getting them more outside will definitely help in the overall of their ocular health there.
Absolutely. I think you nailed it there with the outdoor time, because we know that could be a protective factor of delaying or preventing the onset of myopia. And we are seeing this association with some screen time, which probably is limiting these children from getting outdoors. So absolutely, I completely agree with that.
So parents, have the kids put down the screens, get them outside, please. Okay. What is myopia, and why is it increasing so rapidly in our kids now?
Yeah, so myopia is a refractive disorder of causing that blurred vision out in the distance. But we know that it is also leading to some ocular health risk later on in life because of the stretching that occurs. So really, myopia is the eye growing too fast, too long, and getting weaker, or the vision getting blurrier as this happens. And so we notice that this is really going to be more prevalent now because of what we mentioned with outdoor time being limited. And in the past, we thought it was more driven by genetics. But now we see with the changing lifestyle of children that this is increase of near work, recreational device use with those digital devices, as well as staying indoors more than they should, is leading to this overall incidence as well as progression of myopia.
Now a school, like all of their classes are all on a computer now too, you know. I feel like there's no more books anymore, you know.
Yeah, absolutely, it's all converted
academically
to those digital devices.
Yeah.
Absolutely.
So some studies are suggesting that nearly half of the population is going to be myopic by 2050, based off of our current rate. And some Asian studies have suggested 80 to almost 90% are developing myopia. And again, this myopia progression seems to be a bit more prevalent. So how does this uncontrolled myopia progression, how does it impact their eye health?
Yeah, so what's even scarier when you look at the statistics is that by 2030, the end of this decade, 50% of the North American population is projected to have myopia. So that
Wow.
it's just outstanding to know how rapidly this is progressing and how many more just patients that we're going to be seeing with this condition, particularly children. But when it comes to those ocular health risks, because of that stretching of the eye that's occurring with the elongation with myopia, there's an increased risk of retinal detachment, myopic maculopathy, early onset cataracts, as well as glaucoma. And what I like to tell patients is, whenever we think of that eye stretching, all those structures are being stretched as well. So with retinal detachment, I like to give the analogy of pizza dough. You know, if the back of the eye was lined with pizza dough, which the retina is with tissue, what's going to happen if that continues to stretch? Well, it's going to be more susceptible to breaks, tears, holes. That's the same thing it is with the eyes. So really ensuring that we diagnose myopia at the earliest possible so we can intervene to keep these children at the lowest myopic levels possible.
I think even tracking like an OCT to see and looking at that growth in the fundus over time too, from if the earlier we start, the better it is too, you know, so you'll be able to track that better.
So what is this myopia control that we hear about, and what are some of the options that are now available to parents to help slow this ongoing elongation and progression of the eye and myopia?
Yeah, so the great news is we have an FDA-approved treatment, MySight One-Day Contact Lenses, which is FDA-approved for children 8 to 12 years old at the initiation of treatment. Now, this is a daily disposable contact lens, so the child's going to see clearly, just like they would see in standard glasses or contact lenses. But the innovation within these contact lenses can also slow that progression of myopia in children. And then there's other off-label modalities as well that are evidence-based, such as orthokeratology, as well as some research around low-dose atropine. So definitely many tools in the toolbox that we're able to intervene to keep these children at the lowest levels possible.
I always look at their accommodative system too, and try to get them to relax their eyes as much as possible as well too,
Very good.
on top of doing all those other things.
Yeah, so currently we have some spectacles that are yet to be FDA approved, that are approved in Europe and Asia. But at this time, one of the best and simplest modalities is this MySight contact lens. It's a daily disposable contact lens, so the incidence of microbial keratitis is very, very low as a result. And it's interesting to see how well it slows the progression of myopia and yet not cause regression as soon as it's stopped. Whereas with atropine and some of the Ortho-K, the concern there is they regress and they can increase in their elongation of the eye as the treatment has been discontinued or stopped. So it's part of why I myself am I would say a bigger fan of this MySight daily disposable contact lens as a therapeutic approach to myopia control. So some of the most effective ways at slowing this myopia control I somewhat touched on. I'd like to get your thoughts on some of that and what you've seen in the clinic.
Yeah, so I guess just speaking a little bit more to it is we have the International Myopia Institute, which has really been our guidelines when it comes to implementing myopia control treatment for children. And what they say is that if there is an FDA-approved product or treatment available and that child is a candidate for it, that should be our first line treatment. So I'm so glad that you really spoke to the therapeutic benefit and that you really are an advocate for that treatment for children. But then of course we know not all children are going to be a candidate for contact lenses, so that's when we can use some of that other evidence-based treatment for it. Yeah, but yeah, clinically, I mean, I can speak to a little bit more to the studies, but have you seen anything clinically that you guys have found really interesting or successful when it comes to myopia management?
I think the biggest thing we had several, just the myopia kept getting worse every year, almost doubling. We put the lenses on them, and then with them wearing them and changing them out properly, we finally got that myopia to kind of flat line there. And those big growth spurts, it wasn't changing their prescription either. So it really made a big difference as far as the myopia finally slowing down for these kids. Because you know their habits are not going to change. They're still going to be on screens, still have to do schoolwork. So it definitely did make a big difference.
Yeah, so contact lenses with kids. Let's talk about at what age we can start talking to parents getting started with this myopia control treatment modality. At what age would you start to this recommendation?
I have had parents that, if their kids already were active in sports, I mean, I've put a contact on a 4-year-old because they were into gymnastics. So it's a big thing on how the parents, will they help at a smaller, younger age? But most of mine, I've had 8, 9-year-olds that will do it. The parents kind of sometimes have to help them get them in, but the more they practice, it gets easier and easier for them. But it is a big responsibility, so if the parent is more willing to help, it will be a great option for them. Plus the risk of low risk of infections too, because let's be real, all children are not the cleanest. But it has, I think, age to me is not a factor.
Yeah, when we think about the MySight One-Day Contact Lens, and I bring that up because it is the only FDA-approved treatment currently for myopia control. It is FDA-approved for 8 to 12 years old at the initiation of treatment, but it's always up to the discretion of the provider if that child is younger and wanting to implement treatment. Also that motivation of the parents and the child. And I love that you brought up some of these activities that kids are involved in, because a lot of times we go towards athletes and we know that they can benefit, but all children are really active in their everyday lives, whether it's going to recess, PE, playing after school, and us being advocates for that outdoor time. What better, especially here in Florida, to be spectacle free, where we know it's going to be much easier. And I'll say, too, from the MySight study, 90% of the children during that first 3 years of the randomized controlled study actually preferred their MySight lenses over spectacles. So a huge benefit in their confidence and their self-esteem and how they're living those active everyday lives.
So one thing I just want to mention, in adolescence, incidence of microbial keratitis is actually much lower. It's when you go off to college and you're not overruled with your parents is when we see the incidence of microbial keratitis go up considerably. That's when you're developing your habits. So starting a child at 4, 6, at 8, the incidence of microbial keratitis is some of the risk associated with contact lenses is actually very, very low, comparatively speaking. So I agree. I think starting early is good. Slowing down that progression right away is great. So do these treatments actually stop the myopia, or do they slow it down? What happens to the myopia?
Yeah, I think it's always really important to set that expectation for parents that all we can guarantee is really to slow that progression. We can't guarantee to stop it, definitely not reverse it. And just speaking again a little bit more to MySight, the great news is in that first 3 years, the randomized controlled study where we got that FDA approval, 41% of those children had refractive stability over 3 years. Now that's 8 to 12 years old when they started, where we know that progression can be the fastest, so a huge benefit for them. And then when we fast forward to 6 years of wearing MySight, almost 1 in 4 of them have refractive stability. So just think about that little 8-year-old that might have started out and 6 years later still at that same refractive error. So a huge benefit in what that means for their corrected and uncorrected visual acuity, but also those ocular health risks later on in life and throughout their lifetime.
So will your child still need glasses, or can they just rely on the contact lenses? Will they still need a backup pair of glasses?
I would say so, because say they have an irritation, they still need their glasses, because if they don't have their glasses, they will not be able to see, and we don't want that to regress either. But you never know. You get allergies, get irritation. There's some days that you may not want to put the contacts in too. So I would always have that backup pair.
Agree. Yeah, it's going to be contraindications at times, viral infection, or anything that a child might need to rely on those spectacles. And then, of course, if they're using one of those off-label modalities such as low-dose atropine, you're going to have to rely on glasses or contact lenses for optical clarity. So that's a benefit of at least using contact lenses for myopia control, is you get that 2-in-1 benefit of great vision, but also the myopia control.
Yeah.
So what are some of the side effects we experience from some of these myopia control treatments? What are some of the risk factors we as parents need to be concerned about?
Well, the good news is that we do find that most of the modalities are very safe in children, particularly when we think about MySight. It's a daily disposable, as we mentioned, with microbial keratitis, which is an eye infection. The risk of that is going to be extremely low because you're throwing away the contact lens at the end of the day, and you don't have to worry about that cleaning and storage of the contact lens, which could increase the risk of a secondary infection. So I think it's always really important to minimize any type of adverse events or risk by just following the instructions of the provider with the treatment. And so that could be if using off-label orthokeratology, and then some of the low-dose atropine, if you're prescribing that for myopia management. Of course, we know atropine can dilate the eyes. So just talking about photosensitivity, light sensitivity when going outdoors, as well as with relaxing the focusing system, which we know may occur with that dilating drop as well. So just talking about how that could impact mirror work or that reading ability.
Now, so what are 3 things that parents can do today to protect their child's eyes?
1, I definitely would, if they have not had an eye exam, at least get them in for a baseline eye exam, because 1, if they say they can't see, who knows, maybe they can't see, and I see that a lot. And then the parents feel guilty that they can't see, so 9 out of 10 times you're probably not going to realize that they can't see because they'll try to cheat. And then the other thing I would do is, if they're showing progression, the earlier we get them in, the more easier it would be able to track that change there.
I couldn't agree more. It's really about being able to diagnose at the earliest possible in order to intervene at the earliest possible. So I think those would be two of my top takeaways. And then of course what we know from outdoor time, since we know that's such a protective factor. So you can always start that at any age of really trying to get those children to 1.5 to 2 hours a day, knowing that can either prevent or delay the onset of myopia.
So Dr. Timmerman, I'm interested, what is the theory or the thought behind the MySight lens? How is it supposed to trigger the control within the myopia? What is the theory behind its effectiveness, if you will?
Yeah, so we call it active control technology, is really the innovation behind the MySight lens. So how it works is it's a dual focus contact lens. So essentially the child's going to have great vision and they're going to see just like they would see in standard contact lenses or glasses. But in the periphery, what it does is it puts the eye in a 2 diopter myopic defocus. What that means is it's actually just allowing the light to focus in the eye at a different part, actually in front of the tissue before it hits the back of the eye. And that's really that mechanism of action or how this contact lens is working, because if you have light focusing in front of the eye, there's really no motivation for that eye to want to grow longer, which we know myopia is. The eye growing too long, too fast.
So I was going to say, so it slows, that little blur, which they don't appreciate, slows down that growth in there, in the back of their eye there.
So we're seeing the incidence of myopia increasing. It's fair to say it's likely related to the amount of screen time. So what's a good ratio that we can recommend to parents as to the amount of time they would spend on the screen to the amount of time they spend outdoors? What's a good outdoor to screen time ratio you would recommend to parents?
You
That's
do
a
the
good rule.
outdoor, and I got another one too.
I love that. Yeah, so I really lean on the American Academy of Pediatrics for guidelines in regards to screens. And you know, the thing is, especially with the integration so much in academics, it's really hard to put a quantitative number on that of how much they should be on those. So really trying to limit it for recreational purposes is really what I tell patients and parents. But what we do know is that 90 minutes, an hour and a half to 2 hours a day of outdoor time is really going to be that protective factor of delaying or preventing the onset, and then just really trying to minimize how much that child is on those screens as much as possible for those leisurely activities. And then also when they are on them, making sure to use that proper working distance as well.
And I always say, like, if they're on the younger side, if they are doing only screen time or they're in school and they're studying, if they are only doing up close stuff and it's been 30 minutes and they have not looked up, they need to get in the habit of looking up and letting their eyes relax. Because this constant up close not doing the relaxation part can make that worse as well. And then I always stress pulling their arms away and not bringing it closer to their face, because then it works their eyes even harder too.
So for my kids, I recommend a 1-to-1 ratio. So if you're going to spend an hour on the screen, you've got to get outside for an hour. Okay, it's as simple as that. Because it's a challenge in today's time to get the kids outside, whereas they want to default to these screens. So my rule of thumb is a 1-to-1 ratio as a quick and easy way to keep these kids from progressing with the myopia. So I just want to conclude. I just want to thank Dr. Timmerman and Dr. Russell for your time and your expertise. We've learned a lot today,
Yeah.
and we truly appreciate all the knowledge you've given us. Thank you.
Thank you.
Thank you.
Thank you.